Hello, everyone, and welcome to the Surveillance Advances Seminar Series 2024 to 2025 season. This seminar series is co-hosted by the Public Health Agency of Canada and the National Collaborating Centre for Infectious Diseases, or NCCID. The title for today's seminar is CANCOVID-Preg, a pan-Canadian surveillance program of outcomes for pregnant women and people and their infants who acquired COVID-19 in pregnancy. My name is Robert Sager, and I'm research staff at NCCID. I will be your moderator today, along with Chayu Lin, who is a senior policy analyst in the Data, Surveillance, and Foresight branch of the Public Health Agency of Canada. The NCCID is funded by the Public Health Agency of Canada to provide knowledge and evidence for use in public health planning, programs, and policies related to infectious diseases. We are incredibly pleased to be co-hosting the series with the agency. Both Chayu and I are joining you today from the city of Hamilton, situated upon the traditional territories of the Erie, Neutral, Huron-Wendat, Haudenosaunee, and Mississauga peoples. This land is covered by the Dish with One Spoon Wampum Belt Covenant, an agreement between the Haudenosaunee and Anishinaabe to share and care for the resources around the Great Lakes. Today, Hamilton is home to many Indigenous peoples from across the Turtle Island. We honor the Indigenous peoples who have lived on and cared for these lands for generations. We are grateful for the opportunity to share and call this place home. The Surveillance Advances seminar series has welcomed participants and presenters from coast to coast to coast since our inception in September 2023. While surveillance is the most common term used in public health to describe the process of tracking health events and determinants through the collection, analysis, and reporting of data, due to concerns over its connotations, some have suggested the use of other terms such as public health assessment. We acknowledge that there is still an ongoing dialogue about the use of the term surveillance in public health. For the time being, without a widely accepted term in the literature, we would like to note that we use the term surveillance in the series title to refer to the assessment of and response to public health threats as a core function of the public health systems. Now, before we dive into today's seminar, there are just a few housekeeping items I would like to mention. First off, a recording of the seminar and presentation slides will be available shortly after the seminar on the NCCID website. That's nccid.ca under webcasts. Second, the chat box for participants has been disabled for this session. The hosts will use the chat box to communicate additional information with you. If you have any technical problems with Zoom during the seminar, please email us at nccid@umanitoba.ca. Finally, please send in your topic-related questions using the Q&A tab, and we will try to address as many as possible in the discussion period after the presentation. You can like any of the questions to push them up in priority. We would also like to note that Surveillance Advances is a Section 1 self-approved group learning activity as defined by the Maintenance of Certification Program of the Royal College of Physicians and Surgeons of Canada. The seminar series is also approved by the Council of Professional Development Hours for members of the Canadian Institute of Public Health Inspectors. If you require a letter of participation for your attendance today, please look out for the survey that will be shared after the seminar. Now, with excitement, I would like to introduce and welcome our speaker. Today's seminar will be presented by Dr. Deborah Money. Dr. Deborah Money is a professor and head of the Department of Obstetrics and Gynecology at the University of British Columbia. She is a clinician and scientist in reproductive infectious diseases based at the Women's Health Research Institute, leading several large multi-centered research projects in the vaginal microbiome, HIV in pregnancy, HPV vaccine in women living with HIV, and syphilis in pregnancy. Since March 2020, Dr. Money pivoted her research group to lead 3 large pan-Canadian projects to study the impact of COVID-19 on pregnant women and their infants. She's now studying syphilis in pregnancy. Dr. Money is also the chair of the Infections in Pregnancy Committee for the International Federation of Gynecology and Obstetrics. She has been a successful teacher, mentor, research team builder, and has published more than 250 peer-reviewed publications. Dr. Money has received several awards, including the Queen Elizabeth II Diamond Jubilee Medal in 2012, the Lifetime Achievement Award from the US-based Infectious Diseases Society of Obstetrics and Gynecology in 2019, inducted as a Fellow of the Canadian Academy of Health Sciences in 2023, and was appointed as a member of the Order of Canada in December 2023. On top of all that, she's on the Canadian Masters 060 field hockey team for 2024. Thank you so much for joining us today, Deborah. The floor is yours.
Oh gosh, thank you for that introduction, and probably a little more inclusive than needed to be, but thank you anyway. It's really my pleasure to be here, and pleased to talk to you about this passion project, I guess you could call it, trying to understand COVID-19 in pregnancy. Next slide, please. I would like to acknowledge that I'm actually speaking to you from the traditional, ancestral, and unceded territories of the Coast Salish peoples, the Musqueam, the Squamish, and the Tsleil-Waututh. Thank you. Next slide. So I just want to sort of take us all back a little bit mentally to March of 2020, which I think people might recall was the onset of the pandemic formally. And when that happened, those of us that work in reproductive infectious diseases were acutely aware of there being really very little data on this new coronavirus, SARS-CoV-2, in pregnancy. And so we were scrambling to try and provide the best possible advice to our Canadian international colleagues in the clinical and public health realm, but recognizing that most of our colleagues in infectious diseases and public health were dealing with the sort of the first emergency layers of this problem, and the sort of subspecifics of issues in pregnancy and infancy were not top of mind for everyone else. So we began by collecting the network that we have of reproductive infectious diseases experts and pediatric infectious diseases experts, and began just trying to search the literature and come up with reasonable clinical guidance, and recognize that that was not going to be sufficient. We literally had a handful of papers to go on, which were essentially a couple of very small cohorts with very conflicting data. So we realized we had to try to acquire data to understand this better. And so that was really the beginning of the project. What we did know was that we know pregnancy is an event that is a complex anatomical, immunological, and physiologic changing event. And we already knew that pregnant women had greater predisposition and susceptibility to some infections, even though their immune system still generally works well. But in particular, in part because of the physiologic changes and in part because of the anatomic changes related to the enlarging uterus, lower respiratory tract infections historically have been problematic. And we do know that influenza and other infections, and we knew SARS-CoV-1 as well, had been problematic. The other piece, not on this slide, is that we, right at the beginning, we actually didn't know if this was going to be a vertically transmissible virus. We didn't know its capacity to cross the placenta. None of the other coronaviruses do. Now, neither does influenza, and we were reassured by that, but we couldn't rule out the possibility that this could happen. And so, in fact, at the time, we were kind of bold, I suppose, to go against some of the other jurisdictions in the world to not separate infants from their moms right away at delivery, because the US and China had made that recommendation, and we felt that the data wasn't convincing enough and the damage to be done by doing that was substantive, so we elected not to recommend that, but didn't know really at all whether we were going to get into a vertically transmissible virus. Next slide, please. So we pulled a group together and formed a steering committee, and then an investigator group. Again, at the beginning with zero funding, people just stepped up. It was amazing, and we decided we wanted to provide Canadian data on COVID-19 and pregnancy to try to support optimal care and inform public policy in a data-driven way. So we wanted to start out by determining the burden of the disease in this group of individuals. We wanted to understand the impact of this infection in pregnancy on the infant. We wanted to try to understand, as time went by, this kind of evolved with time, the relationship with the variants as they rolled out and how that would specifically affect maternal outcomes, pregnancy outcomes, and infant outcomes. And then as the vaccination, as vaccines became available, again, didn't know that that would happen, but once they did, we wanted to understand vaccination in pregnancy and the impact on them and their infants, which we can certainly discuss later, but as you can appreciate at the time, was a very controversial issue. Next slide. So just to walk the timeline first, then I'll go through methods. We literally started before the actual announcement by WHO because we were all getting, as I'm sure many of you were, the information of this virus appearing and starting to prepare for guidelines right at the beginning. So we began in March 2020. We assembled this group together, a phenomenal group. I've got a slide at the very end that lists the large group of individuals. And we began by developing our protocol. And in order to do that, we did look to other colleagues around the world. Unfortunately, I've had some connections with various groups, and the first group I would say that was coordinated was out of Switzerland, CANCOVID-Preg. We kind of borrowed part of their name, but anyway, very kind. But they had a consortium of countries and had a data collection a data set that we looked at carefully and decided to try to parallel the early international data sets, partly because it's not rocket science. We kind of all know the kind of things we want to collect, but also as much as possible, we were foreshadowing the possibility of data sharing internationally and wanted to have some comparable data set. So we wanted to look at case definitions, and we had initially decided on PCR positivity, our data collection variables. We set up a data management and stewardship plan and brought in biostatistical support. So we did all of this work through 2023. And we actually have only finally got all of our data now. Hard to believe, but true. We can talk about that as well if you want. We were very grateful, ultimately, once we kind of became organized, to be funded through the Public Health Agency of Canada, through CIHR, and in part by Public Health Agency via the Federal Immunity Task Force that had enveloped funding. Next slide. So this is using the word surveillance, as was shared earlier, a surveillance program attempted to be across the country. In the end, 9 provinces and 1 territory were able to participate, and we were the coordinating center at UBC in British Columbia. We used initially, as you well remember, PCR testing was the gold standard for determining a SARS-CoV-2 infection. Later on, the rapid antigen tests came in, and PCR sort of went by the wayside outside of hospitals. So we had to make a protocol adjustment for that. We decided to collect data on pregnancies from March 1st of 2020 and right the way through to infection and pregnancy to the end of December 2022. Because we didn't have variant diagnoses per person, we utilized the variant dominance for the time period in Canada, and that was the way of analyzing by variant. And as you recall, the variants tended to sort of come in and quickly dominate. So we felt this was reasonable to do. We also needed comparison groups, and we were fortunate to be able to get data from Statistics Canada for comparison to non-pregnant, comparable aged females. And we were also able to get information from CAI on pregnancies in this contemporaneous time period that were not affected by COVID-19. And we wanted the contemporaneous time period because of other indirect impacts on lockdown and things that were being suggested as impacting pregnancy outcomes. Next slide, please. So in the end, we have been able to collate data on over 33,652 mother-infant pairs in the country. And the distribution across the country is seen here. The non-population reflection is in part related to how we were able to collect data from different jurisdictions. Ontario has a very robust method of collecting perinatal data through Born Ontario. And so I would say, to be fair, that's probably the most complete data set from there. Quebec, although worked extremely hard to be participatory, we had to get data from their province from specific sites that were able to participate. Manitoba, I think, was reasonably comprehensive, as was British Columbia, and Alberta is a little overrepresented, we think in part related to their differences in public health policy and vaccination, but also perhaps related to slightly more robust ability to get full population data. We're very pleased one of the territories were able to participate and include some of their cases. And we did have, I think, a pretty reasonable participation from the Maritimes to include a pretty close to pan-Canadian representation here. Next slide. So this is essentially a summary slide of the entire time period. And the little dotted lines are to reflect the different variant time periods. So pre-Delta is the first block, Delta is the second block, and then Omicron being the third block. And what you can see in the gray bars, I guess they are the actual absolute case numbers. The blue line is hospitalization for COVID-19 during pregnancy. And you can see we were seeing significant hospitalization rates in the early part of the pandemic, and these dropped abruptly in the Omicron period. And then ICU admissions, which of course would be an unusual phenomenon for a young, healthy female population, were notable in the orange line, and again fell to extremely low in Omicron. And I've got some more details on this coming up. Next slide, please. So just to give you a feeling of who these individuals were that we were able to collect data on, we had probably I would say quite a typical age for pregnancy in Canada now. Pregnant women are on average much older than they were decades ago, and so the mid-30s is actually sort of the average. So that's not different. And we were able to collect race to a point, and we'll talk a little bit about that in a minute, but it was, in the end, reasonably representative of the Canadian population, although it shifted over time in the pandemic. And because we had not had the time and opportunity to do appropriate Indigenous consultations and engagement in the early part of this rapid rollout, the Indigenous designation is actually captured under other. So that's I would say, a weakness of this data. Next slide. Average BMI was again not dissimilar and didn't change over time. We wanted to look at comorbidities to see the influence of specific common problems in pregnancy. So gestational diabetes, gestational hypertension were more common in the earlier cases. perhaps reflecting more vulnerable populations being exposed and infected, but then asthma became a more predominant comorbidity in the Omicron era. Next slide. So this is gestational age at the time of diagnosis. That's a little bit of a mistake on the black title. We didn't know exactly when people were infected, but we knew when they were diagnosed, and we correlated that with their gestational age. There was some question about, again, there was many questions as all of this was rolling out, but one of them was, were women going to be more susceptible at certain gestational ages, certain stages of pregnancy? And really, we didn't find that to be a remarkable thing. The less than 14 weeks data is not as solid in that those are often undiagnosed pregnancies or to be determined pregnancies. And so we aren't as, I would say, as confident of the data in that gestational age period. Next slide. So here's getting down into a little bit more of the nitty-gritty data. We had historically seen issues of prematurity associated with severe respiratory illness in pregnancy, and there was a signal for this early on in some of the other papers, so that was something we drilled into quite quickly. And we found, in fact, that there was a higher rate of prematurity in the early across the board, but in the early phase of the pandemic more so. So pre-Delta, actually almost a 10% rate of preterm birth. And of course, I'm sure you're aware that every preterm birth is associated with higher morbidity and potentially mortality for the infant related simply to the prematurity. And there was a question of, was this because of sort of clinician panic? If you have COVID, you're going to deliver early and so on. So iatrogenic delivery, and it didn't really look, it was about half and half, iatrogenic versus spontaneous. So we felt that probably wasn't a big driver. Cesarean section rate we tracked, it's about the same as the very high cesarean section rate we have in this country. And we were very reassured to see, even though there were some early reports in the literature of stillbirth being a common problem associated with COVID, we were not seeing this to be both a change over time and not different to the baseline to speak of. And losses, again, our data not so solid here. So I would say the losses in pre-Delta, although statistically significantly different, I would really be cautious with that data. Next slide. Okay, so this is trying to really drill down on the complications, the maternal complications potentially associated with SARS-CoV-2 infection. So we wanted to understand, there's lots of anecdotal reports and experience that people in this space were seeing of ICUs with pregnant women that they wouldn't normally see pregnant women in, hospitalizations and so on. So we wanted to really look to see whether this was a sort of reactive impression or real. So what we were able to do was to compare pregnancies with SARS-CoV-2 infection to reproductive age females, and to see if there was a difference if you were pregnant when you got SARS-CoV-2. And so what we saw here most dramatically in the earlier parts, but we saw a significant risk increase for hospitalization associated with being pregnant in pre-Delta and Delta for sure, and not really significant in Omicron. And I'll come to how we responded regarding that, but it was a very real phenomenon that we were seeing pregnancy being a risk factor for hospitalization. And we were as careful as we could possibly be to code hospitalization only if it was because of COVID, because as I'm sure you're aware, there's other reasons why pregnant women can get hospitalized related to pregnancy events. We tried to separate that out as best as possible. And then ICU admission was also significantly higher, although the absolute rate wasn't high for otherwise healthy for the most part, pregnant women. This was quite a high rate of ICU admission, and 3 to 4 times higher than the non-pregnant comparators. Next slide. So then this is looking at pregnancies affected by SARS-CoV-2 versus pregnancies not affected by SARS-CoV-2. And here we see an increased, moderately increased rate of preterm birth over the baseline in the country. And we saw no significant difference in cesarean section rates or, as I alluded to earlier, stillbirth, which was reassuring. Next slide, please. Okay, so this is into a couple of quite complex slides that I know are probably a little bit hard to read, but what we were very interested in is understanding both the uptake of vaccination in pregnancy and the impact of vaccination in pregnancy as to whether it was helpful or not. So what we have here are rates of vaccination in pregnancy as to whether the individual received a vaccine pre-pregnancy, and we would presume there would be some potential pregnancy protection, whether they received a vaccination during pregnancy before their SARS event and their COVID-19 event, and then did they get a vaccination even after infection, which was kind of just helpful to know vaccine uptake, and then after pregnancy, because there was some concern about it, and were people delaying their vaccination till after pregnancy. And we obviously had a fair number without data in the gray bar. So it's not surprising we see a huge uptake in vaccination in 2022, but as you'll recall, vaccines became available in the early part of 2021, and they were rolled out by risk categories, primarily by age and to some degree by other comorbidities. And so it wasn't till the spring that we really see in 2021 any significant numbers of vaccination in pregnancy. Next slide. So this was us having a look at whether being vaccinated, and this is before you have your SARS-CoV-2 diagnosis, impacted the outcomes. And we wanted to look at the three major adverse outcomes that we had noted in our previous data. So this is the first tranche here is hospitalization in the three different variant periods. And what we see is a substantive protective effect of vaccination in Delta. Obviously, pre-Delta, we didn't really have vaccine available, but in Delta we had so the relative risk here is vaccinated versus unvaccinated. So reduced risk of the adverse outcome from 13% or almost 14% to down to 5% in vaccinated. And then we did see a risk reduction in Omicron. And we thought that was particularly important to look at because there was a debate whether reduced adverse outcomes in Omicron were related to variant not being as aggressive or robust versus coexistent access to vaccine. So we did see, even in Omicron, that vaccination was still protective for hospitalization. And then when you look at ICU admission, the same directionality is seen with a reduction in ICU admission in Delta from almost 3% to 0.25%, and then in Omicron, 0.8% down to 0.05%. So these are, I think, clinically significant and statistically, obviously. And then preterm birth, we didn't see the same, we see a directionality here, but it's borderline in terms of whether it's significant, but we did seem to see some protective effect with vaccination for prematurity. Next slide. So what did we do with this data? Well, we really had approached this as even though we were kind of a research group and a surveillance group, it depended on how you talked about us, but we really wanted to get the data out as quickly as we possibly could for the purposes of decision making, even though it was interim analyses that we were doing as we went along. So instead of waiting for the time it takes to get peer-reviewed publications, which we still are doing, we put reports out, which we posted and also shared with our public health leaders across the country and with Dr. Tam as well. And so right away in December of 2020, we were recommending that we go ahead with vaccination for pregnant individuals because of the nature of the vaccines, no reason to expect them to be problematic in pregnancy, and the risk of COVID-19 already being seen to be substantive. Then what we were able to do in early 2021 with our interim data is really get a understanding that the vaccination was looking protective, and that in fact that we should seriously prioritize pregnant individuals as the vaccine rollout was happening by age categories. And we were able to approximate the risk to a pregnant individual with COVID to be similar to those in their late 50s, and that was about the time when the late 50s age group was accessing vaccine, and which was earlier than obviously the age group of those individuals. So that we thought was particularly important for the protection of this population from these adverse outcomes. And we were really pleased that public health jumped up and made these recommendations. Next slide. So just to try and summarize what we think are key takeaways, is really that vaccination before or during pregnancy reduced the risk of hospitalization or ICU admission. And we have other data that actually isn't from this, it's from other studies we've been doing in terms of the safety of vaccine, which is incredibly safe, even though there was a lot of anxiety about it at the time. We did notice, and actually I didn't really highlight the slide on that, but we did see in the early part of the pandemic a disproportionate racialized population that was being infected with SARS-CoV-2, and one could presume this may be related to the front-facing workers during the early pandemic period that were being more exposed than those that could seclude at home and protect themselves from exposures. Comorbidities played a small role, but they did play a role in increasing disease severity. And another takeaway was it took an enormous amount of time and effort to get permission to do data sharing, which delayed our ability to get our full data set that we now have until actually very recently because of legal agreements between the provinces. And we're obviously talking a lot these days about interprovincial transfer of things and data, and we have pretty rigid boundaries in our country right now. And I think if we were going to do lessons learned, if we were to do this again, hopefully not soon, but if we wanted to try and respond in a more rapid and equitable manner, we would want to be able to share data quickly, albeit safely, but quickly. And this was de-identified data that we at a group level, but still very difficult. We would want to be able to collect sociodemographic data in a more fulsome way. And we really needed a better mechanism to engage with our Indigenous communities and leadership to permit us to be able to do this data collection with them about Indigenous individuals who we believe were being more disproportionately affected, but we weren't able to pull that data out. So that I think is an ongoing challenge. Next slide. So I know I brushed through this, but we, I think, have time for questions. I just want to say I am here speaking on behalf of a massive team, huge group of people, many from our team at UBC, but people across the country took a lot of personal time to make this possible, with leaders like Eliana and Brenny in Alberta, and Isabelle Bucron in Quebec, and Vanessa Poliquin in Manitoba, and Sprague and her group at Born Ontario were phenomenal. And we literally had people, Phil Murphy in Newfoundland actually did the data collection himself personally. So phenomenal contributions to make it possible to have this pan-Canadian data. So I'm going to stop the formal piece there. I don't think I have another slide. I think that's me. And then I'm happy to try and answer questions or engage in a conversation about this. Thank you. Yes, funding, yes. And we were very graciously funded by, initially by a little wee grant from the Women's Health Foundation that actually gave us just a little bit of money to get started, to then apply for the different funding from the large agencies. Thank you.
Well, thank you so much, Dr. Money, for presenting the overviews of findings from the CANCOVID-Preg. Not pivoting your team, this massive team did back in March 2020, really set a strong foundation for a national surveillance approach to study the impact of COVID-19 on pregnant women and their infants. So thank you so much for the work. I also want to take this opportunity to add an observation. In our last seminar session, Dr. David Barkridge from the Public Health Agency of Canada presented Vision 2030. It is about what public health surveillance should look like in Canada by 2030. And in his presentation, data sharing and linkage was noted as one of the key opportunities for action to advance Vision 2030, as well as prioritizing equity-focused data collection. And from Dr. Money's presentation today on CANCOVID-Preg today, those two areas were also highlighted under the key takeaway that we just heard. I just want to say this alignment really shows the importance of the need to act on those opportunities for action, and CANCOVID-Preg can certainly serve as a good example for inspiration. So thank you. We will now begin our discussion period. Please send in your question for Dr. Money using the Q&A tab. You can also choose to upvote other people's questions. Everyone is welcome to participate in the conversation. We'll try to address as many questions as possible, but we may not be able to get to all of them. Okay, Dr. Money, the first question came up, I think that's when you were talking about the comparison between pregnant women and also, is there a likelihood of pregnant women seeking care more often than non-pregnant women, which may increase the number of hospitalizations?
You know, I mean, I think that's a good question. And that was something that was discussed amongst ourselves when we were first getting the higher hospitalization data. Was it anxiety? Was it care providers being more nervous about pregnant women and bringing them in more often? And we tried to do as much as we could there, both from people on the ground with their experience, and also from looking at the data to see if we could better understand if this was perhaps an overage of hospitalization. The reality on the ground was pregnant women were terrified to go to the physician in the hospital. In fact, we were having a difficult time getting them in for real serious bleeding issues, other major concerns. So that, I think, was, if anything, biased the other way. And emergency rooms would say that they had trouble. Hospital beds were in dire demand, and so admission to hospital was strictly limited, even for pregnancy. So I think it's a good question. I don't think that's the phenomenon you're seeing.
Thank you for that response. The next question that we have is, given that in the pre-data phase, vaccine were not really available, using it as a reference category to assess outcome by vaccination status may have resulted in inflated results. Do you have any comments on that?
Um, well, well, it is an unvaccinated phase. We still compared within category though, like Delta to Delta, vaccine, non-vaccine, and Omicron, vaccine, non-vaccine. So I don't think it inflated our within variant comparisons that way.
Thank you. Well, now we're like 5 years after the first, like the March 2020. The next question is, have you been able to collect data on long COVID with women who were initially infected during pregnancy?
That should be our next project. We weren't. We didn't include that. It is harder to pick up the cases of long COVID because of the way they come to healthcare providers. They're not sort of tracked in the way that just a COVID diagnosis, yes, no, was tracked in the middle of the pandemic. So it is a question that is, I think, unanswered, but our group really wasn't positioned to do that.
Thank you. Hopefully there will be opportunity down the road to
Yeah,
continue.
and I mean, it's something to think about is these are the kind of sequelae to a big issue like this that we don't really have good surveillance on, that I'm aware of anyway, where we have like a whole track of people with long COVID with or without other, issues like being pregnant. So that's something to kind of put in the think about cat box of how one might set it up in the future.
For sure. The next question that we have is, are there any suggestions based on the available data on best time to receive COVID-19 vaccination? Are we at a stage to consider passive protection for the newborn and consider delaying immunization to later trimesters?
Well, that was a topic of hot debate, actually. I think what we observed in our data was that primarily this problem was a problem of the infection in pregnancy. So the morbidity to the mom, and I think you can figure out that being admitted to hospital or ICU for a serious respiratory illness is not good for your fetus, and being born premature is not good for your fetus. So impact on those adverse outcomes really require vaccination at the first available opportunity. Hence, the current public health recommendations are, when appropriate in season that COVID vaccines are available, you just vaccinate your pregnant woman somewhat opportunistically then. And you don't try to delay to a later gestational age, as we do for other things like pertussis, as we're doing now for RSV, where they are vaccines for infant protection. We also did some immunologic studies, data not presented here, looking at the transfer of antibody from mother to infant for those women who received vaccine. And in fact, although there is a somewhat diminution in the titer by gestational age over time, there is still a measurable antibody in infants regardless of time period in the pregnancy. So currently what we're saying is vaccinate for maternal and infant protection when you can. And the worst thing would be to say we get another bad winter of COVID, you don't want to be delaying for infant protection and end up with a sick mom. Sorry, that was a bit of a long-winded answer, but hopefully that's
Thank
the
you
question.
so much. Now the next question brings us back to the methodology. Is there a sampling method used in the study?
The short answer is the best method we could get in the province that we were dealing with. It was not a perfect methodology. The reality of how we are able to collect data in Canadian provinces and territories is varied. So if I can be more specific, in Ontario, for example, we had what I would call, and probably BC, we had close to the most optimal sampling method, which is we were able to, I believe, determine a SARS-CoV-2 diagnosis in a pregnant woman and pull that data across the province in a centralized way. And we had it done sort of more systematically in Ontario, and in BC, we had a reporting system where if you were SARS-CoV-2 positive and pregnant, we could pull your data. However, the sampling method in Quebec was purely opportunistic and not systematic. And so because of the Quebec legislated limitations on waiver of consent, we had to consent or try to. And so we had essentially sentinel sites that were large volume maternal care sites who tried to get a hold of patients and their data. So that was problematic. So the sampling is the best we could do, I think, is the answer to your question. And the most, I think, because of the numbers, I mean, we're over 30,000, I think in the end, I think we feel that we've got a pretty representative set.
Thank you. I think the next question brings us back to talk about other determinants of health. Did the team also take into account the impact of stress and social isolation?
Great question. We would love to have been able to do that. We did not have really a mechanism to do that. In that we have geography a little bit, and you can sometimes sort of make some assumptions there, but we sort of hoped that comparing both COVID infections in pregnancy, not pregnant, so the sort of whole impact of being pregnant during the pandemic was to some degree considered there, and then COVID versus not, COVID versus not in the pregnancy, and then COVID being pregnant or not pregnant. However, it's, you know, the short answer is no, we couldn't, even though we would have liked to.
Thank you. Okay, this next question received more votes. So during the vaccine rollout, the product monographs for the men's 3 vaccine, the mRNAs, are from Novavax, all reference different pregnancy registry. Had you happened to have reached out to the other 2 from Moderna's proprietary and Novavax that point to the C. viper and compare the findings?
We haven't. What I didn't talk about is that we did participate in a global prospective meta-analysis that was coordinated out of George Washington University in the United States. And they had, I'm going to challenge my memory here, I think at least 30 countries, maybe more, where we were all able to, in one way or another, share our country specific data with them. And in some cases it was, what was it called? AfriCovid, or there was a consortium of African countries, there was a consortium of European countries, there was a group in the UK, actually 2 groups in the UK, a couple of groups from US, we had Mexico, a couple of South American groups, Hong Kong participated. Anyway, so it was really pretty broad, and broad low and middle income country and high income country differences. And so we've got data, you know, pretty much across the board that gives us pregnancy outcomes, to some degree vaccination outcomes, that show our data set is comparable to most of the high income country data, and not really different, or different than the low-income country data in terms of the fact that they couldn't access vaccine to speak of, and they had a lot of adverse outcomes. So, so we haven't gone with a comparison to Moderna and Novavax.
Thank you. The next question is, were breakthrough infections accounted for when evaluating vaccine effectiveness?
No. We didn't have No, we didn't. And so it was kind of assumed that if there was breakthrough infections, they were just there in the mix with the vaccine outcomes. And we were strictly comparing, did you get vaccinated versus didn't you get vaccinated? And it was that initial SARS-CoV-2, like before your first diagnosis of SARS-CoV-2. So it would have been interesting to do that subset. We should maybe, I was trying to think if we have the data to do that as a sub-analysis. Not sure that we do. But good question.
Thank you. The other question that we have is, were comorbidities taken into consideration in collating the data for hospitalization and ICU stay in the pregnant woman?
They weren't in the original raw data tables, but they were in our sub-analyses. And we did see higher rates of complications associated with particularly asthma, actually.
Okay, thank you. Another question that we have before is that you mentioned that sharing the data across the prevention line has been a challenge, and then the data set finally just kind of come together. Eddie, how was this challenge overcome by CANCOVID-Preg?
A massive amount of patience. I mean, I think ultimately we had very, very committed leads in every province who were willing to keep pushing and keep working with us, and working with the legal teams or the contracts teams that were putting up every obstacle known to man to share data. So it was persistence, I would say, and patience, and it took much longer than anyone imagined it would take.
Okay, thank you. I guess the next question that we have is more about application. Would it be difficult to carry out similar studies for other vaccine or other disease? Would there be a significant data challenges?
Yes, there would still be. The reason I can say that with a little bit of confidence is that we did try to use this approach and this, at least a subset of this team, to begin to try and look at congenital syphilis. Because although congenital syphilis is tracked at a public health level, syphilis in pregnancy and the gestational age of diagnosis and the treatments and all the permutations of syphilis are not currently in indicator data from most public health units. So we have been trying to collect syphilis in pregnancy data in a sort of similar fashion. I know it's not vaccine related, but in some respects, the sort of treatment, I think, is like a surrogate for vaccine and the sort of the way you data collect. It has proven to be more difficult since the pandemic.
Thank you. Earlier during your presentation, you also talked about the impact on the policies. So what were the biggest challenges in translating the data into practice, and how were those challenges being addressed?
You know, I have to say, to be fair, that wasn't, there was a huge willingness on the part of our national groups and international groups to look at data as it came out, evaluate it, and determine what was best recommendations. So Society of Obstetricians and Gynecologists of Canada were reasonably early adopters of recommendations from this data, even though it was not peer-reviewed and published at the time, but it was peer-reviewed, but within the group, and you know, it was early data, interim data. So we did manage to influence guidelines actually quite fluidly through the pandemic. And our public health leaders and colleagues, and Theresa Tam in particular, was very willing to hear from us and to look at the data and to make fairly rapid decisions, in particular with vaccination recommendations in pregnancy, for example, because they had no, you know, there was a few papers in the literature, and then we were at least presenting fairly reasonable Canadian data on which to make policy decisions. So I would say that was pretty good, pretty responsive under the circumstances.
That's great to hear. I think we're going to end the discussion period with a future, kind of forward-looking type of question. How can Canada be better prepared for the future public health threat based on the lesson learned from CANCOVID-Preg?
Well, I gather you heard from Dave Buckridge last seminar, and he and I talked a lot about this going through it together. We were both involved in the immunity task force, and I would love when the dust settles in peacetime, as people often call it, for us to think about how we could set up a baseline system with sort of, in the case of us, where we're thinking pregnancy and infants, there's basic things you want to know, and you clip on pathogen du jour into that and say, how could we set up a surveillance system in the provinces and territories with sort of preset agreements on data sharing that had a core basic set of predictable things we would want to know, and then an ability to ramp that up at a very short time period should the next SARS-CoV-2, let's call it for the moment, appear. And we would be able to respond quickly, efficiently, like some other jurisdictions could. I mean, to be fair, the UK was pretty fast. Scotland was quite fast because of their national surveillance mechanisms. And I think we could do it. We just have to plan.
Mm-hmm. Take you. That would be a dream but hopefully it's not just a dream. We'll turn it into a vision and then take some action.
We are definitely advocating for that, let me tell you.
Awesome. Thank you. So on this note, I'm going to take a moment to thank all of you for joining us today, and of course to our speaker, Dr. Money, for presenting the information and the result on the CANCOVID-Preg. A reminder that the recording for today's seminar and presentation material will be accessible for viewing on NCCID's website in a few weeks. Please also take some time to complete our survey for this presentation. You can scan the QR code on this slide to access the survey, or look for the link in the email that will be sent out shortly. In the post-seminar survey, this is where you will also be able to request a letter for participation for your attendance today. Due to the schedule conflict with an upcoming conference that many of you might be attending, the Public Health 2025, which is hosted by the Canadian Public Health Association, our next seminar will actually take place on April 22nd, instead of the last Tuesday of the month on the April 29th. So please join us on Tuesday, April 22nd, 2025, 1 to 2 p.m. Eastern Time or 12 to 1 p.m. Central Time to learn more about IMPACT. That is short for Canada's Immunization Monitoring Program Active. And IMPACT is a pediatric hospital-based national active surveillance network for adverse events following immunization, vaccine failures, and selected infectious disease that are or will be vaccine preventable. If you have any other question about the Surveillance Event Seminar Series, please visit our webpage at nccid.ca. That concludes today's seminar. Thank you all very much for joining, and thank you, Dr. Money, again for your wonderful presentation. Thank you.
Thank you. Pleasure to be here. Thanks, everyone.